Hello, everyone. Welcome to the Community Leaders Embedding Dementia in Public Health Practice webinar. We're happy that you're here. Thank you for joining us and being here today. My name is Kat Woodall-Colcom, and I'm an Associate Director of the Healthy Brain Initiative at the Alzheimer's Association. I'm joined by my colleague today, Eva Jackson, who is also an Associate Director of the Healthy Brain Initiative. Thank you for attending today's webinar, which is hosted by the Healthy Brain Initiative and is funded through a cooperative agreement with the CDC. As a reminder, the recording will be shared with all registrants. Any personal recording of the webinar or use of AI assistance to record is not allowed. If you would like to use the closed captioning, you can enable it using the toolbar at the bottom of your screen. Please feel free to put any questions you have during today's webinar in the Q&A box, and someone from our public health team will respond. After today's webinar, we will send a follow-up summary with the recording. Today, we'll begin with our learning objectives, followed by a brief overview of the Healthy Brain Initiative and its capacity building programs. We'll then hear from alumni from the HBI Roadmap Strategist and HBI Roadmap Champion programs as they share how they initiated conversations around brain health, dementia, and caregiving, and transformed those discussions into meaningful community action. After alumni sharing, we will have time for Q&A, so please utilize the Q&A function. During the webinar, you will learn how leaders initiated conversations about brain health, dementia, and caregiving, understand what resonated with public health leadership to launch and sustain efforts, and explore how to partner with the Alzheimer's Association to advance roadmap implementation locally. To help us accomplish these learning objectives, we have three great presenters who I'm excited for you to hear from. We'll hear from Tracy Cordero, the Health and Human Services Director with the Pueblo de San Ildefonso, Sierra Rodriguez, the Risk Reduction Program Manager at Central District Health in Boise, Idaho, and Alicia Park-Shell, the Community Health Manager with the Confederated Tribes of Grand Ronde. Ahead of hearing from our speakers, I'd like to share a bit more about the Healthy Brain Initiative and how these leaders are using a public health approach to dementia. Our vision states that everyone deserves a life with the healthiest brain possible. This is the grounding we approach this work with, and a reminder that while the work we do and that public health does operate at the population level, the impacts, effects, and outcomes are felt on a much smaller scale. We encourage you to keep this vision in mind as you hear the rest of today's presentation. Many of you are here today. You may have a higher working knowledge of dementia as a public health issue, but to both level set for this group and to provide you with an elevator pitch that you can use and take back to your local communities, I'm going to give you our argument and our rationale for why Alzheimer's is a public health issue. Because prevalence and costs are substantial, the impacts are serious, and it couldn't be a public health issue if there wasn't something that public health could do about it. There are a lot of ways to tailor this argument to help advance your priorities, whether that's risk reduction, early detection, emergency preparedness, data and surveillance, workforce issues, or caregiving. For more information, you can visit the recently published Gerontologist supplement on the impacts of the HBI and BOLD programs, or watch a short animated video that makes the same argument, and both of these links will be shared in the chat with you. The HBI Roadmap series is a joint project of the CDC and the Alzheimer's Association and is a public health strategy to help promote and advance brain health and dementia. The state and local roadmap for public health is an overarching framework for state and local health departments. It provides a set of 24 actions to enhance collective impact across the life course. The HBI Roadmap for American Indian and Alaska Native peoples provides 13 actionable steps for strengthening public health response to Alzheimer's and other dementia in American Indian and Alaska Native communities. These roadmaps focus on the indigenous determinants of health and includes inclusive imagery and graphics with examples of public health action from different American Indian and Alaska Native communities. This is a very unique approach. Other chronic conditions don't have a regularly updated list of expert-developed actions to pursue and implement. And there's a lot that needs to happen and be done on dementia, and a lot of directions that we could each go. So the Roadmap series helps steer collective action in a way that public health is used to working. The action framework for each roadmap consists of 4 domains built from the essential public health services. On the left, you can see the framework for the state and local roadmap, and on the right, the framework for the American Indian Alaska Native Peoples roadmap. Our work is centered around health equity and culture and surrounded by the areas of public health practice across the life course, from risk reduction, early detection, caregiving, and community clinical linkages. This framework covers the life course and spans all of the facets of population health, and it's intended to be a comprehensive structure to promote and protect population health and well-being for all. The wheel depicts the interconnectedness of these elements, showing the essential nature of each in a successful strategy to improve brain health. The 4 domains build on one another, which helps to drive community impact, as you can see here on the screen. The domain of focus today is workforce. Public health is responsible for training and preparing the public health and healthcare workforce to provide culturally centered and appropriate care to people at risk for or living with dementia, while also supporting caregivers. To aid in these actions, the Alzheimer's Association established 2 capacity building programs. The Roadmap Strategist and Roadmap Champion programs strengthen local and tribal public health capacity to address brain health, dementia, and caregiving. Through these programs, awardees receive funding, education, peer support, and technical assistance to implement a public health approach to dementia. Both programs are grounded in the HBI Roadmap series and are expertly developed guidance for integrating action on dementia and into public health practice. Across both of these programs, participating organizations designate a public health leader to serve as a strategist or a champion. And these professionals work to embed dementia into public health by assessing community strengths and needs, building partnerships, expanding organizational capacity, and sharing dementia-related knowledge and information. Strategists and champions also develop and implement an action plan built from the HBI Roadmap series and is tailored to their local community and needs. First, we'll begin with the HBI Roadmap Strategist program. This program helps build capacity within local health departments to address brain health, dementia, and caregiving. Led by the Alzheimer's Association in collaboration with the National Association of County and City Health Officials, or NACCHO, the program supports experienced public health professionals who serve as HBI Roadmap Strategists. And these are system change agents working to advance the public health approach to dementia in their communities. By the end of each cohort, the aim is for all participating health departments to have increased capacity to address brain health, including increased knowledge about dementia, new and enhanced community partnerships, increased prioritization of dementia in their department, and sustained efforts and staff time devoted to dementia. Results from the first 4 cohorts show strong momentum. Participants showed a 35% increase in knowledge, a 16% increase in comfort with key capacity building skills, and a 100% increase in prioritizing brain health, dementia, and caregiving. And a 5th cohort is currently underway. Before we go any farther, I would like to just say thank you to our partners at NACCHO and the Emory Centers for Public Health Training and Technical Assistance. The successes of these past 4 cohorts and the current foundation of this 5th cohort would not be possible without them. And next, I would like to turn it over to Sierra Rodriguez. She is a former roadmap strategist, and she's here to talk about her experience and successes addressing dementia as a public health issue. After we hear from Sierra, I'll turn it over to my colleague, Eva, to talk more about the Roadmap Champion program.
I suppose I should start by unmuting myself. Hi, everyone. My name is Sierra Rodriguez. I'm the Risk Reduction Program Manager at Central District Health, which is a local health department in Idaho. And I'm really excited today to share a little bit about how our health department kind of approached this topic, really moving from conversation and awareness into concrete community action. So my goal is just to paint a picture of why we prioritize brain health, how partnership really impacted and shaped our approach, and then talk a little bit about some of the really cool things that we did. Next slide. So I want to start off by providing a little bit of context just about Central District Health, which I'll refer to throughout this presentation as CDH. CDH is one of 7 local health departments in Idaho. We serve 4 counties, Ada, Elmore, Boise, and Valley. So really a mix of both urban and rural communities, each kind of with their own niche personalities. We serve the largest population hub in the state, so over 600 to 1,000 people. And really our vision and mission is healthy people in healthy communities and partnering to promote and protect health in our communities. And we were a recipient of the Alzheimer's Association's Healthy Brain Initiative grant funding in 2025. Next slide. So I wanted to kind of just preface like why brain health and why did our health department really see that as a priority? And it was because our statewide data paints a pretty grim picture. So lots of relevance for public health. We see that over 30,000 people aged 65 and older are living with Alzheimer's. And there's a huge toll on caregivers. So we know that there's over 73,000 family caregivers providing support to people living with dementia, equating to over $116 million of unpaid care. And we know that it also costs to the systems as well. So it's estimated that there's $213 million as the cost of the Alzheimer's to the state Medicaid program. Next slide. So rather than asking, should public health be involved, we really asked, well, how can public health be involved effectively? And I think here at Central District Health, we really see ourselves as connectors and trusted technical assistance providers. So much of the work that we're already doing on my team focuses on chronic disease prevention and risk reduction. Things like tobacco cessation, diabetes prevention, nutrition education, physical activity. So rather than creating something entirely new, we wanted to intentionally center brain health work within the work we were already doing and to help our partners see it as an essential part of an overall health across the lifespan. So because brain health shares so many common risk and protective factors with existing efforts, public health, in my opinion, is uniquely positioned to bridge programs, align messaging, and support partners in practical and actionable ways. So our role in this project was really less about ownership and more about facilitation, elevating resources, connecting organizations, and providing some technical assistance that helps brain health become embedded in the day-to-day practice of the work that we're already doing. This work was also made possible by strong leadership support. Our leadership really bought in to kind of the things that I was mentioning above, which allowed us to take an integrated kind of cross-program approach and reinforced that brain health is not a siloed issue, but rather a shared priority that really aligns, again, with our broader mission of risk reduction and prevention. So with this in mind, we used our grant funding to convene partners for a series of 3 meetings, with the project goal being, as you can see on the slides, to catalyze and sustain efforts to improve brain health in our communities by strengthening interorganizational networks and collaborating to bridge reduction efforts. We had over 10 agencies involved from various backgrounds, and you can see them listed there. Next slide, please. So really our project timeline and kind of how we structured it, we had 3 meetings. So in the first meeting, we really just convened partners for some general introductions. This was the health department's first time meeting some of these partners who worked more so in the space of caregiving or direct service for people who have dementia or Alzheimer's. So it was a great opportunity for us to kind of really get together and learn about what each of our respective organizations were doing so that we could better understand where there was room for that cross-collaboration. And it was also where we spent some time just kind of level setting, introducing the project, talking about that statewide data, why this was a public health priority, and what the goals of us meeting was to do. So after that first meeting, we met again and we completed a SOAR analysis, and we'll go through some of those findings here shortly, but really just wanted to, as a group, decide the direction that we were going to move forward, which really set the phase for our 3rd meeting, which was action planning. And I'll talk about some of the fun things that came out of this project. But so those meetings took place March, April, and May, and then we actually convened monthly meetings from June to December, and that was really for work time, group updates, and kind of just serving as a touch point to not lose momentum. Okay, next slide, please. So some of our SOAR finding themes I wanted to highlight here, really the strengths, there was a shared understanding that there was strong community-based programs and engagement already happening, that there was robust partnerships and collaborative initiatives, and that there was lots of access to existing tools and statewide planning resources. The opportunities that the group saw was really to enhance collaboration and communication. So yes, there was lots of partners, but some of those partners weren't connected. There was disjointment in communication. Really expanding health and wellness access. We spent a lot of time talking about that, both in mind for just general community members, but also caregivers. And then really talked about leveraging existing resources for greater impact. So let's not reinvent the wheel, but how do we strengthen what we're already doing? And I'm sorry, it looks like my slides got a little funky, but I'm happy to share out the correct version so you can see all of the things after the fact. Our aspirations, this is where I asked the group to dream big, like in a perfect world, what would this look like? So we talked a lot about increased awareness and access to brain health resources at the community level, enhanced education and support for caregivers and providers, really promoting prevention and risk reduction, not just in the older population, but across the lifespan and starting young. And we also spent a lot of time talking about strengthening support systems for caregivers and families, because we know that they are a huge resource and they're often hard to tap into. So really talking about even like prevention for caregivers. And then we talked a lot about like, well, how are we going to know that what we're doing is working? So what would those results look like? And we talked a lot about increased reach, active participation and engagement in the activities that we chose to do, and then really spending the time to really storytell and demonstrate that community impact and success. Next slide, please. So that kind of really prefaced what we wanted to keep in mind while we developed our action plan. So the group came up with 3 priority areas from after we completed that SOAR analysis. The first was just to increase awareness of brain health and risk reduction strategies across the lifespan. We recognized that within the group, there was a ton of knowledge and a ton of existing prevention education that was happening, but we really wanted to embed brain health as a conversation point, right? Because it's not often that our tobacco coordinators, for example, were talking about the connection between tobacco and the brain. They were most commonly talking about the connection between tobacco and lungs or mental health. And so really equipping our existing programming to feel comfortable talking about brain health as a portion of why their topic is important. Priority area 2 was to increase provider, which we kind of defined as both medical and non-medical, and I'll talk about what that means a little bit more later, about dementia risk reduction activities, and then awareness of the different tools that are available to them. And then for our third priority area, it was really to expand capacity for collaboration with partners to strengthen networking and partnership. It is so powerful to put partners in a room together and to let them brainstorm different ways to collaborate, but we really wanted to be intentional in providing space and opportunities for folks to have that magic happen. Next slide, please. So to talk a little bit about some of the fun things that came out of this project, again, priority area 1 was, again, just really focusing on increasing awareness of brain health and the risk reduction strategy. So you'll see some fun pictures of me and my team out and about. We have a giant inflatable brain that our tobacco program actually bought, that we took out and did tons of education in community settings about brain health and risk reduction. So some of our goals was to participate in at least one back-to-school event with the Mega Brain for youth, because we know, again, risk reduction happens across the lifespan, and we really wanted to hit those younger populations. We did that. Lots of education happened both at schools and community events. And what I think was really meaningful and impactful is it wasn't just the health department owning this work. It was all of the partners that we brought to the table as well. And then the second kind of objective under this priority area was to spread awareness of risk factors by creating short form videos. And I think one of the most cool things that came from this was we actually worked with a local school district's career tech program, and the students created a marketing video that we are going to use and put into movie theaters and other places that really talked about brain health. So it was student-led, student-made, student-created. So we know it's speaking to young people. And if you want to go to the next slide, I'll play that video for you. It's just a short clip.
I wear a helmet because even the pros do it. I wear a helmet because I want to come home for dinner every night. I wear a helmet because it's kept me standing here today.
I wear a helmet because I know it's the right thing to do.
Awesome. So yeah, such a great example of partnership. We had someone from the state actually go in and provide education about brain health to the students, and then we really turned it over to them and let them create the messaging that they thought would resonate with their peers. So super fun example of how this work can be collaborative and engage young people. Under our second priority area, we really wanted to get information in the hands of providers. So we wanted to promote the Alzheimer's Association's Essentials training, which had a stipend locally to provide. So we did that via sharing across social media, partner newsletter platforms. We wanted to train fit and fall proof instructors, which are local volunteers that offer exercise and mobility classes in community settings about brain health so that they can share that information with the people that are attending their classes. And then we also wanted to explore integration of brain health into community paramedicine. So we had some internal meetings to discuss feasibility of that, and we were able to provide the paramedics boots on the ground information about brain health, screening tools, and local resources, and provide a little bit of that education. Next slide. And under our priority area 3, our goals were really to provide educational presentations to 2 of our local health coalitions to expand collaboration in some of our more rural, hard to reach counties. We wanted to establish partnerships with at least one farmer's market to provide vouchers for fresh fruits and vegetables in coordination with brain health education, which we did. You can see there in the photos. We set up on a couple. That was a rainy day Halloween event closer to the end of the season, but we were able to provide brain health education and free tokens for any patrons to get access to fresh fruits and vegetables. And then lastly, we were able to help support the YMCA hosts an annual brain health symposium in our region, and so we were able to just help support with some education and resources, little bags and squishy brains to further the conversation at that event. Next slide. So really just to kind of recap our lessons learned, what I took away from this project is that public health absolutely has an important role to play in advancing the conversations about brain health. There is also an opportunity for public health to engage non-traditional partners in this work. So really getting creative about who we're inviting to the table. Again, some of those direct care providers or folks working with caregivers really highlighted some of the gaps that public health maybe didn't have in mind when we first approached this work. And lastly, again, these efforts are sustainable and scalable if we integrate brain health messaging into existing program areas. So lots of opportunities for what I would call quick wins. Thanks. Next slide. That's it for me. I really appreciate everyone's time and look forward to answering some questions in the Q&A. And my contact information is on the next slide should anyone need to get a hold of me for any additional questions. Thank you.
Thank you so much, Sierra. We really appreciate you being here and appreciate the chance to learn from you. I echo the comments of getting to see the amazing work by the youth. Love the brain. It just seems like such a fun program. So thank you for sharing. My name is Eva Jackson, as Kat shared, and I am an associate director with the Healthy Brain Initiative. I have had the honor of learning from the Roadmap Strategist program and working with some incredible partners to adapt that into our Roadmap Champions program. And so we partnered with North Dakota State University's American Indian Public Health Resource Center to adapt the Roadmap Strategist program from being for local health departments to being designed for tribally led health organizations and urban Indian organizations. And we work with Emory Centers for evaluation on this project. And next slide, please. So here you can see we are in the second year of our Champions program. Just some incredible leaders, both in urban and tribal communities. And so I'm going to go ahead and just turn it over to them to share about the amazing work they've been doing. So next slide, we have Tracy Cordero, who's going to be presenting first from the Pueblo de San Ildefonso. Tracy, the floor is yours.
Thank you, Eva. Good afternoon. Goete hopa kuchinaksi jamash bahana suta awe matsasa kukite me osuta. My name is Tracy Cordero. I'm from the Pueblo of Coach T, and I work for the Pueblo of San Ildefonso, which is about an hour north of me as the Health and Human Services Director. And I just want to quickly acknowledge that if we've been in the same circles about HBI and brain health, you may have seen these slides. And I want you to know that the copy and paste was intentional, okay? It's not just on accident. This first slide here is the Black Mesa of the Pueblo that I work for. You'll see that the title is called HBI Landscape Assessment, and this is from May of 2025. And our journey into brain health and learning about dementia and Alzheimer's really started here. We were awarded the HBI Initiative HBI grant, and that really propelled us to learn more about what we didn't know. And so next slide, please. As I talk through some of our population demographics, I'll let you all just read some of the information about our community. We're one of 19 sovereign pueblos in the state of New Mexico. We have similar lifestyles, but are also different in several ways. So this information is specific to San Ildefonso. We have tribal enrollment of about 750 folks, and about 143 of those are seniors. The age of senior here in the community is 50. And we have about half of that number living on tribal land in our immediate access. Next slide, please. One of the things that really one drove our work, but one of the things that our work around brain health is rooted in is the community. Everybody here is so close-knit, knows what's going on in everybody's life, knows who's driving a new car and who's not, and everything in between. And that's also one of the major strengths of our community and one of the major strengths of our health team. It's because of the intimate relationships that our diabetes, who's certified CHW team has. Our CHR team, we have 2 staff in that program, our family advocate team, our Healthy Kids, Healthy Community team. Each one of those staff members has really strong relationships with the community. Next door to our health building is the senior center where they serve lunch every day. And so it was really in those informal settings where there's a health checkup, where we're sitting around the lunch table. And we begin, I say begin because I'm not from here. I started with the Pueblo almost 2 years ago. And so for me, it was in those spaces that I began to hear, remember Auntie so-and-so used to wander? Yeah, we weren't sure if she had dementia, but her memory started, oh, she was so grumpy, but that's just how she was. She was just getting old. And then pair that with calls from community members to our CHRs asking for support in caregiving. And if you have contract IHS funding, you'll know that caregiving is not what those shares are for, right? There's limited scope with our CHR federal funding. So all at the same time, we have folks talking about what may or may not have been dementia. We have folks talking about the need for caregiving, and we have the HBI call for proposals all at the same time. And when these things happen all at once for our team, it's a recognition that we're on the path and we're headed to do the work that we're supposed to be doing, and the stars are aligning for us. And so I just can't highlight enough that for a public like ours that didn't have any data, because we rely on IHS, the community was our source of data. And that was our source of the most accurate data. And it was through these informal conversations that we said we should probably look into what dementia is and what the impact on our community is. Next slide, please. So as we begin to have these sort of informal conversations about what is dementia, did so-and-so have it, where do we go to learn about dementia? As I mentioned, the call for proposals for HBI was out. And in reading through the application, the roadmap for Native Americans, American Indians, we realized that those risk reduction practices were already the things that we practice in our inherent way of being. And so this intergenerational methods where caregiving is not an option, it's a responsibility, right? Where our cultural language and life ways already come with the very complex brain exercise that we need to keep our brain, if we think of it as a muscle, strong and active. The other piece that, sometimes in grant writing, a rural community is seen as a deficit. We're far away from resources. But for us, it's one of the things that protects us from our way of life being disrupted, right? It's a barrier and it shields our way of being. And then our indigenous expressions, whether that's agricultural, whether that's hunting, whether that's, in this case, pottery, the Black pottery that the Pueblo is known for, we have these risk reduction factors. And so how do we pair what we already know how to do as a people into the science of brain health? And it was being able to write an application for funding that was rooted in our community strengths, and moving away from the narrative, which oftentimes has been my experience in Native communities, like we don't have enough, right? Or we're not enough, so give us something to help. In this case, we have it, but give me the guidance so that it's structured in a way that's meaningful, not just to the brain health and the doctors and the Western way of knowing, but in a way that's meaningful to our community. Slide, please. So this is as we were awarded, right? One of the things that, and I just cannot thank Eva and Ashley enough. One of the things that the HBI grant allowed us to do was roadmap our brain health program through a logic model. And so those discussions about, well, what do we even know about dementia? What does our data set even look like? Where do we go to find more? Outlining it in a roadmap allowed us to answer those very questions. And so through this work of the community and deep partnership and gratitude for Julie Rogers and Dawn at the Alzheimer's Association here in New Mexico, the New Mexico chapter, through Eva and Ashley, through Megan at IA Squared, we were able to implement a series of trainings for the community and also for our staff. IA Squared also gave us the tools to develop, we're using the word loosely here, but toolkit for our community to distribute. And that's what you see in the bottom right-hand corner. And so it was these conversations that led to community members being able to advocate for themselves in doctor's appointments. One of the pamphlets in the picture is questions to ask your doctor about memory loss. I personally, I'm not a CHR or CHW, but I personally, in just the last month, have had 2 conversations with seniors who took this tool along with the symptom tracker to their doctor's appointment, and we'll be able to say, no, that's not what's going on. Somebody else, I need to talk to somebody else about this. Get another doctor in here or tell me when I can come back to ask for another doctor. And so that advocacy and being able to be strong in what our seniors know and feel about their own health. The second piece that we were able to implement is our caregiving services. And so this is a new service to the community where our caregiver is on contract, has a rotation of about 6 clients, and has participated in the trainings that we've offered. And so she's able to use the symptom tracker, not even just for memory or but changes in mood, right? Changes in diet, changes in daily routines. Whereas a month ago, this gentleman got on the tractor and drove to lunch every day, and now suddenly he can't remember the route to his field. And so we just want to be mindful that what we've developed for dementia and Alzheimer's already aligns well with some of the things that we're doing. And that symptom tracker has allowed us to do this. Next slide, please. I'm really bad at slideshows or making anything creative, so sorry for all the crazy colors and fonts on the screen. But in May of last year, part of our work in the HBI was to submit that landscape. And in that landscape, one of the slides in there was this May 2025 slide. That said this slide is blank because that's what our database looks like. It's blank, and everybody who should have this data on our behalf isn't immediately accessible to us, mostly IHS, right, and a senior program at the time. And so that was our starting point. As a result of the HBI funding, we were able to come up with these different data points to say, okay, we don't have any surveys out, we don't have any doctor visits, but of all the 20 seniors sitting in the room, they knew at least one person who had symptoms at the very least of dementia or Alzheimer's. The other two major takeaways for us were that we didn't know that dementia and Alzheimer's are not the same thing. We also didn't know that if you had these in your family, it was a sure thing that you were going to get it. That was our understanding, that if my mom had it, if my grandma had it, it's only a matter of time for me. And that isn't the case. The other thing, that I think the biggest takeaway in terms of existing programs was what's good for the heart is good for the brain. And so we have a really robust diet already doing. And this data, I'll just share for you all to read through if you can with my crazy colors. But that just helped us to know that infrastructure, how do we just be more intentional about plugging it in? And so this last set of font here in the green text, it's being more intentional about building that into our brain health practices and the existing services. A key piece, I had the privilege, again, thanks to Julie and Dawn, I went to the Alzheimer's Summit in late February. One of my major takeaways was the US Pointer study that gives us just a breakdown of not only how do we preserve brain health, but make it stronger. How do we sort of re-energize our brain by practicing these 4 components, right? Diet and exercise and cognitive exercise and regular health checkups. And on its face, it seems really simple. So why don't we just do that with cadres of seniors, cadres of middle-aged adults, and start plugging them into these pattern of habits? So that US Pointer study, you'll see, maybe Eva is who I talk to the most, eventually that this is going to be a standard practice for us, building in that model into the things that we're doing. The next thing is the Healthy Brain Habit Tracker for a targeted audience. So those that we've identified to be most at risk or most in need. We're going to make sure that when we have a community event, you're not just going to get a flyer or the marquee, but we're going to send you invite because we know that more than other folks in the community, you will benefit from this. And so let us help you in this way. Another key outcome of our participation in HBI was conversation with leadership. And so we were able to say, you know, we don't really know much now, but we're going to submit this grant and see what we end up with. Okay, we submitted this grant, and as a result, here's what we know now. 85% of our seniors rely on IHS, and 85% of those seniors have not had an audiology appointment because it takes a year to get an appointment at our local IHS. And so that has led our tribal leadership to advocate at the local headquarters and regional IHS offices to say, we need to fix this. This is like a direct correlation to brain health, and we can't even get in there to get our ears checked. And so it's really empowered the opportunities for our own leadership to advocate at the national level. The other part that leadership has bought into because of where we were able to move this work is that now we'll be implementing healthy brain in the workplace from the Alzheimer's Association. So we're on the list to receive that curriculum or enroll in that program when it comes out. We recently reclaimed the senior services program from a consortium organization. And so now we will be at a place to have a dedicated staff to make sure that brain health is a constant in senior programming and not just when one of us can get to it, because right now it's not anybody's one job. Lastly, this has really furthered our desire to define health standards for ourselves, right? So a lot of the time when we seek grant funding, these are the metrics, and this is the idea of what it means to be healthy, despite the fact that our way of life may not align with what those metrics look like. So we're going to work really hard this summer to define what it means to be a healthy San Ildefonso program. And we know now that brain health is going to be a core element in that. And just, again, being intentional about what's good for the brain and how that aligns well with our own cultural values. So I think that's it for me now. I did a bad job about listing my contact information, but Eva has it and I can put it in the chat. Thank you.
Thank you so much, Tracy. I love listening hear you share your story and the journey that your Pueblo has been on to go from a place of conversation to changing how you're structured and the focus and the core elements. So really appreciate you sharing that. Next we have Alicia Park-Shell from the Confederated Tribes of Grand Ronde. So Alicia, the floor is all you.
Hi, I'm Alicia. I am the Community Health Manager for the Confederated Tribes of Grand Ronde. Within the Community Health Department, we have multiple programs, and one of those is our Brain Health Program. Next slide, please. I wanted to share a little bit of our demographics. In the state of Oregon, there are 9 federally recognized tribes. The Confederated Tribes of Grand Ronde is one of them. We are a confederation of over 27 tribes and bands from Western Oregon to Northern California, and we have roughly 5,000 to 5,500 enrolled tribal members. The number on the presentation was from about 6 months ago, so this number is consistently growing and moving at all times. Within our service area, we provide services to almost 2,500 tribal members. Of those 2,500, 660 of them are tribal elders. Our service area is the gray area that's highlighted on the map of Oregon. It includes 7 counties. I realize I listed 6. One of the ones that I missed is Tillamook County, which is right on the coast. The tribe is located in between Yamhill and Polk. So the county line actually runs right through the middle of the reservation. Next slide, please. The Community Health Department is a team of 12. We all have varied life experiences, training, qualifications, and community ties. Myself, for example, I am not a member of the Confederated Tribes of Grand Ronde. I am an other Native. I am an enrolled member with Cherokee Nation, but I was raised in this community, and so I have really close ties to the majority of the tribal members that are here, and my culture practices were raised with the tribal members that were here. We have driver wellness assistants. They are more of an entry-level position for somebody who's wanting to get into healthcare. They provide all of our medical transportation, non-medical transportation, which is trips such as grocery shopping or running some errands. And then they do all of our prescription delivery. We have two health promotion specialists. This is a CNA level position where it provides a lot of medication management, care coordination, and is they have their own caseload of tribal members. And then we have two community health aid fours. One of them is a paramedic, one of them is an RN. They take the higher acuity elders who need more hands-on case management. They do some wound care. Those two and myself, being a medical assistant, have protocols that are signed off by our medical team as well as our EMS team. So we're allowed to do a lot of things in the field, such as blood draws, just specimen collection, wound care. Periodically, we'll have to do some tube feeding. So we do a lot more of the more technical hands-on care. We have an elder justice coordinator in our department because we have our own basically adult protective services program here on our reservation. So any reports of elder abuse, neglect, and exploitation come to us, and we do the investigation in partnership with the tribal police. And then we have a dementia care specialist who does all of the primary education on dementia, the caregiver support, the early detection work, and really just community education. Next slide, please. On the reservation, we're really fortunate. I listed some of the services that we offer here in community health. This list is consistently growing. But on the reservation, we have our own tribal EMS and fire, and we have tribal PD. Our Elder Activity Center is our elder meal site. They also do activities daily. They run field trips pretty regularly. Our adult foster care, we have 3 lodges that house 5 tribal elders, and it is full at this time. We also have elder housing. All of this is within walking distance to our community health department, so we're able to respond pretty quickly when we have an elder in need. We have a cultural committee who does the traditional crafting, gathering, and activities and events. Our Health and Wellness Center, which community health is located within health and wellness, has medical, dental, pharmacy, behavioral health, and optometry. And then we also have a public health department that houses a dietitian, a naturopath, a bunch of educators. We have an environmentalist, and that department is also consistently growing and adding programs. Next slide. The purpose behind our brain health program, we being in the tribe and having elders that we're treating in their home and providing services, we really saw that the beliefs behind dementia was that it was just normal. We had elders who were struggling consistently. We were getting in really acute situations where they were ending up in the emergency room, and then no one knew what to do because they couldn't go home safely. When I pulled our diagnosis rates, it was extremely low. So we wanted to reduce the incidences of dementia in our tribal community and be proactive about it instead of consistently being reactive. We wanted the education that went out to be culturally relevant. We wanted to connect our tribal elders with resources to encourage the early detection and diagnosis of cognitive impairment and dementia. And we wanted to provide caregiver education and support to address their issues, along with resource connections that they have here, both on the reservation as well as through the state, and improve their quality of life and reduce their burnout. Next slide. Getting leadership buy-in was actually really easy for us. I utilize data. I am a numbers person, and so I love data. What I didn't love is that out of our almost 1,500 elders that were seen in 2024, we only had 33 of them diagnosed with dementia. Some of our elders that I knew we had barriers with due to experiences that we had been dealing with them with, such as wandering, they weren't even included in those 33 who were diagnosed with dementia. So sharing that information with our leadership, as well as the real stories and lived experiences, what are we dealing with on a daily basis? And what are the barriers that we're having to the care that they're providing or receiving? And then the impact that dementia is having on that person or their families. And as we started to share the barriers that we were experiencing in the community with the elders, our leadership had also experienced it, but no one had talked about it. Next slide. The social determinants of health are the non-medical factors that can drive health outcomes. When we look at our social determinants, we really refer to our indigenous determinants of health, and how we can focus on the strengths that we have here in our community and ensure that respect and integrating cultural knowledge is done consistently. We put a focus on maintaining our sovereignty, trauma-informed care practices, speaking the language. We include the language wherever we possibly can, promoting cultural connectedness. I think every department on the reservation hosts events in some way pretty regularly, and we make sure that we're doing it in a culturally respectful way. We look to our elders to share that traditional knowledge, both with each other and with our youth, and then expanding on access to services. So our department, I like to say we don't say no. We say we'll look for a way, because we don't know what needs our elders are going to have until they share it with us, and then we figure out how we're going to solve that with them. Next slide. Our community conversations were interesting. We initially went into talking with our elders about dementia, and they were like, nope, we're not going to talk about that. We stay home, we keep it in our home. Our culture has raised us and told us that we keep our elders at home, in their home, and our issues in our home. So I completely understood where our elders were coming from when they didn't want to talk about it. That all had to do with the stigma and their perceptions of memory loss being a natural part of aging rather than a medical disease, and that there are things that can be done to ease the burden on both that person and their families. We decided to meet with our elder committee, who is a group of elected elders by our tribal council, and we shared the statistics on Native American diagnosis rate, as well as our statistics here on the reservation. And then we shared what normal aging looks like as opposed to dementia aging, and how early detection doesn't have to be a burden. It can be a blessing in many ways. It can allow them to prepare. It can give them all the education they need, and we can look at modifiable risk factors to slow the progression the best that we can, and create community connectedness and support. The biggest thing that they told us was stop saying dementia. So we shared, they spoke, and we listened, and the outcome was Shlush Zum Zum, which means good brain. So that was where the program Brain Health came from. Next slide. To continue the conversations after we met with elder committee and after our program was named and we knew how to talk about dementia with them, we went to every event that we could. They didn't have to be events that were just hosted by Health and Wellness. We went to social service events. We just randomly popped up at their houses periodically and shared information. And we kept it pretty lighthearted to begin with. We had events that were just good, healthy brain events, and we didn't even bring up dementia at all. We also didn't restrict it to only our elders. We had healthy brain conversations with our youth, with our adults, with education department. We had them everywhere. We then began having one-on-one conversations with our individual clients that we case manage about their goals and the barriers that they were experiencing and actively problem solving those with them. We did that with the intent to normalize cognitive screenings. So several of our elders that we were case managing, we were seeing cognitive decline. Once we talked to them about their goals and barriers, we shared that we can do screenings to see if there is any cognitive decline or indication of it. And they were pretty accepting. We did it in their homes, and then we expanded to the Elder Activity Center. Our elders that are here on the reservation are pretty competitive, so it became a challenge amongst the elders to see who got the higher score. It made it interesting because they would yell it across the dining room. But we didn't stop there. Once we had a screening that was done that was positive, we did wraparound care. We scheduled their cognitive assessment with their provider for diagnosis. We followed up with them in their home to offer support. We rescreened if we needed to rescreen, and at minimum, they became an annual rescreen, and we have a roster of elders who have had a mini cog done. We provided support to our caregivers and identified what a Native family caregiver is, and we celebrated them. Us as natives don't see ourselves as caregivers because we're raised to take care of our elders. So we really identified that and called it out pretty specifically. And we just remain present. We're everywhere within the community. Next slide. We have partnerships everywhere. On the left-hand side, you can see all of the campus resources that we have. But off campus, we've worked really hard with our state AAAs, Adult Protective Services, Northwest Senior Disability Services, to really understand how they can support and how we can support them if they have somebody who lives off of the reservation. We know our contact with the Alzheimer's Association. We have some home care providers that we're close with. We have a university that offers a law program where the students come in and write wills and do estate planning. We partner with our Northwest Area Indian Health Board and their BOLD program. So we really look at partnerships wherever we can find it because we know that we can't do everything here and we have to look outside too. Next slide. Some of the ways that we lean on the Alzheimer's Association, the biggest thing is we know who they are. We make contact and we meet them. For all of the education, we don't spend the time recreating the wheel. If the education is out there, we use it. And that's both education that goes into the community as well as education for the team. My entire team has done the essential Alzheimer's training. And all, even if we've worked in healthcare for a long time, still found it value added. And community events, we bring them down every chance that we get. I think that might be my last slide.
Well, thank you. Yes, that looks like it. Thank you, Alicia. I love the power of combining the data that you talked about with connecting with leaders' personal connections and how leveraging those partnerships and listening to your elders really can make a difference. So I like to end on the power of community and the hope that that brings. So I think all of our leaders here today really were able to share different stories of working in different communities, different settings, different structures, and how much hope there is for continuing to work in this space. So I just want to say thank you to everyone for joining today and being a part of this change. A couple of resources I do want to mention. So on our next slide, we have the link to our monthly newsletter. So this is where opportunities come out if you wanted to apply to be a strategist or a champion in the future, for example, or any other resources. We share research and all sorts of other great updates as well. So if you're not already signed up for that, I encourage you to do so. Next slide. We also have a public health curriculum. So this is designed for current and future public health professionals. So whether you're a student, whether you are training folks, or whether you are working in public health, I didn't learn about dementia when I was studying public health. And so we created this as a resource through our team to help fill that gap. Whether you want to learn about risk reduction, whether you want to learn the basics, all free, all online, and it does have free CHES credits available as well. Next slide, please. We also have a slew of other amazing resources to support this work. So these will all go out as well in our follow-up email, but this includes our 10 healthy habits for the brain. We have brain health messages ready to go. We have information about reducing dementia risk that looks at the science. We have information about hosting community convening. So if you're looking to start community conversations, this is a guide on how to do that. And then we also have more information about the social determinants of health, resources, and science that go along with that. So lots of great resources. Feel free to check it out. Email us if there's something you're particularly interested in as well. Next slide, please. So as we said, our vision is really to ensure that everyone deserves a life with the healthiest brain possible. We're working to do that, working with you, working with other leaders in community. So please continue to stay in contact with us, take advantage of these opportunities, and thank you for being here today. Our last slide. We do have an evaluation survey, so when you get logged off, you will get the opportunity to fill this out. We really appreciate your feedback. It guides how and what we do. So thank you again for being here, and please take a chance to tell us how we did. Thank you, everybody.